Hello, and welcome to the Limitless Ladies Network, where our mission is to help women build holistic self-care. We're limitless in sharing lessons to advocate and drive insightful, empathetic self-care. The following disclaimer applies to all episodes and content shared on this show. The views and opinions expressed on this podcast are those of the host and guests and do not necessarily reflect the views of Limitless Ladies Network or its affiliates. The information and advice provided on this podcast are for general educational purposes only and should not be considered as professional, medical, nutritional, or therapeutic advice. The content shared on this podcast is not intended to diagnose, treat, cure, or prevent any disease or health condition. Listeners are advised to consult with a qualified healthcare professional before making any changes to their diet, lifestyle, or health routine. By listening to this podcast, you acknowledge that you are aware of the limitations and potential risks associated with the information and advice shared on this show. You release and hold harmless Limitless Ladies Network and its hosts, guests, and affiliates from any liability for any damages, losses, or injuries that may result from the use of the information and advice provided on this podcast. Welcome to today's webinar, sponsored by the New London Natural Health Center. Today, we're getting upfront and personal with Natalie Walters, talking hormones and methods to manage our declining hormones so we can age with grace, not just with grit. Natalie is a board-certified adult nurse practitioner with over 30 years of experience helping people to optimize their health and well-being. Natalie specializes in functional integrative medicine, which is personalized, preventative, and seeks to find the underlying causes or root causes of illness. Natalie's approach is food first and lifestyle first. She also uses herbs, supplements, peptides, and at times pharmaceuticals. Her passion is partnering with and guiding people towards improving their health and well-being, and she believes that optimal health is achieved through mindset, lifestyle, and self-compassion. In her free time, Natalie is a yogi and yoga instructor, enjoying spending time with her family, gardening, walking her dog Bindi, and strength training. Good for you. So welcome, Natalie. It's my pleasure to have you on the show and talk today about hormone replacement therapy.
Thank you. I'm so happy to be here. Excited to talk about this. Yes.
Yeah, great topics for us. So let's just dive right in. As we're talking about hormone replacement therapy, I actually have been on hormone replacement therapy for the last 6 months or so. So I may share a little bit of information about what I've gone through as we talk through some of this stuff. Natalie obviously is the expert here, who has all the background, and I will just kind of fill in some of the things from my own personal experience. So Natalie, can you provide us with just a general overview for those that don't know of actually what hormone replacement therapy, or HRT, a lot of people will call it, including any different types of hormones and the delivery methods?
Sure, sure. So I think most people consider it to be estrogen. Maybe some people consider estrogen progesterone, but you know, typically what I do in my practice is I offer estrogen, progesterone, and testosterone. Most women don't know, but before we go through this transition, we have 4 times more testosterone in our bodies than we do estrogen. So, testosterone is in all bodies and it's responsible for a lot of good things. So yeah, so those three primarily. And then, there's different forms. There's oral forms, there's creams and gels. There are pellets which get put under the skin. And sometimes there is available injections as well. It's not something I typically do for women, but it's a form that's available.
Yep. So I can say that I have tried the pellet when I first started hormone replacement therapy. And I was a little shocked, I guess, at, they put it underneath the skin, as you said. It kind of goes in the buttocks area, so you don't really see it, but they slice it slightly open, put in a pellet, and it was kind of a shocker, I guess, just knowing that I had this bioidentical thing inside, and it just basically would adjust to my body, right? And I could see that it initially did not seem to do too much, but then after a little while, like there was this massive peak, right? I got to the point where I felt like I was a teenager, right? So things were really good. Things were moving along. I felt just a lot of more sensations because I had lost that through going through menopause. And then switched over because I was not wanting to get that pellet inserted because I think it's every 3 to 6 months. Is that right?
Yes, I think so. Yeah. Yeah. I don't insert them, so I don't know all the specifics, but yes, I think it's every 3 to 6 months. Yep.
Yeah, so I want to say it was about it was like in the third month and it came up again. And when I had talked with someone, I was like, yeah, I think I want to try the cream, which I've been
Hmm.
doing. And that seems to be more of a steady kind of application. It's daily, but it is just more, I've seen where I do have more energy and things like that, more drive, I guess, as well. But it is a daily thing. The one benefit to the pellet I thought was that it was kind of like set it and forget it, right? I didn't have to think about it. Whereas now every day I had to kind of put cream on.
Yeah.
And then you
You
have
do
to worry
adjust
about
to it though, right? Yeah.
I
Yeah.
did. I just made it part of my
Hmm.
routine. So it's, in the morning, just get out of the shower. I put lotion on every day anyway. So for somebody that
Hmm.
doesn't do that, it might be a little different, but I put lotion on and then I would just apply that towards the end. So,
Hmm. Hmm.
um,
Yeah. Yeah. I mean, testosterone cream or gel is daily. If you take progesterone, that's a pill that you take that at night. And then, estrogen can be either a patch that you change twice a week, or you could do gel daily as well. So yeah, there's some options there, definitely. But
that's,
usually, if you're not doing pellets, is a
yep. And I
daily
also do
routine.
the progesterone daily. So I take that at night. And then I also do
Mhm.
the patch for
Yeah.
the estrogen. So,
Yeah, that's the most common regimen for most people. Yeah, and they do well on it.
yeah, seems to be a nice even keeled for estrogen balances without any major mood swings necessarily, dips and drive again. So it's good to have that balance.
Yeah, definitely.
As we are talking about a couple of those things, though, I'm just going to kind of throw this out there. So, what are some of because I know you said you don't do pellets. So, what are the
I
reasons
don't.
why?
Mhm. Um, Pellets, when you insert them, you get initially, like you said, you might not feel anything right away, but you initially get a very big surge. And then, gradually over the next 3 to 6 months, that's come down. Um, Typically women tend to have more side effects with hormones. Anytime hormones are going up or going down a lot, most people feel that, and not in a good way necessarily. That's when women tend to have side effects, when there's a big dose jump or a big dose decrease, like when we go through menopause. So I don't my philosophy is, I'm trying to help you feel better. I just don't want to add those variables in. And then there's a risk for infection as well. You're making an incision in somebody. But yeah, the big peaks and valleys with the pellets, and even injections, that's an issue too, peaks and valleys. So yeah, it's not something I prescribe. I know there are people out there that do that. Um, Pellets, I think, could potentially be good for somebody who's been on hormones for a while and is very stable on them and at a low dose. But yeah, I find that, the patches and the creams and the gels tend to work better because you're getting a daily steady dose. You're not getting a bunch of peaks and valleys.
Right. And I can attest to the peak and the valley
Yeah.
on the pellet.
Yes. Yeah. It's you feel that's when we get side effects. Yeah. Yeah. That's when we tend to get side effects, is when it's, rocketing up or plunging down. Yes.
Yeah, you would think that it would be a little bit more like stable going down or like coming to its plateau, but yeah, it does seem to kind of almost give you a crash.
Hmm. Hmm.
Um,
Yes, definitely.
with the creams, any side effects with those at all?
Not typically. I mean, testosterone cream or gel, depending where you put it, I usually have women put it on their abdomen or their inner thighs because you can transfer it to pets or people, so those areas usually don't come in contact with people during the day. Some women do get a little bit of hair growth where the testosterone gel or cream goes. I haven't had anyone report it yet, but I've heard that that can happen. Other than that, really, not any problems. I mean, with testosterone in general, you can get some extra chin hairs. You can get acne. Now, if you're getting acne, then it might be too high of a dose. And you can also get hair thinning or hair shedding, but that's usually a dose issue. It's not usually the testosterone. So that's why, for me, I start women low. I start women at 2 milligrams. A man's starting dose is 50 milligrams. So I start at two, and most women do really well with like 2 or 3 milligrams. Yeah,
Wow.
it's kind of perfect. Yeah, not everyone. Some people need it higher, some people need lower.
Yep.
But yeah, so yeah, with the gel and then with the estrogen patch, um, with estrogen in general, you can get common side effects of breast tenderness and vaginal bleeding. So that would mean that the dose is potentially too high with the estrogen. And then progesterone, you can get some bloating can be common and some mood changes, but both of those things are usually transient. So they kind of usually pass. Again, like I was saying before, if your progesterone is level is, I don't know, let's say 10, and then you start taking progesterone and that level goes up, while it's going up, you can get some side effects. But most women do really well on all of those. And if you start people on a reasonable dose, but a low dose, and then go slowly, yeah, I have most people do really well.
What about estradiol?
So estradiol is what we use. So there's three types of estrogen. Well, there's one when you're pregnant, but typically there's, estrone, which is
Mhm.
E1. There's estradiol, which is E2, and then there's estriol, which is E3. So
Okay.
when we do hormone replacement or bioidentical hormone replacement, we use estradiol. So we use the E2 form of it. Um, and so, yeah, everything I said about estrogen, yes, it's the same thing. But estradiol is the one that's most abundant in our bodies. The E3 we have more of when we're pregnant, and there's even an E4 they think, when we're pregnant. And then estrone is the one that can be a little bit toxic. So, that's not something we typically use, to replace anything. That usually, gets converted through the liver and eliminated. So yeah, but it is another form.
So in estradiol, then that's in the patch, and is that also
Yes.
in like the vaginal cream?
Yes,
Okay,
both. Yep.
gotcha.
Yep. You can also get estriol or E3 in vaginal cream as well. Some women use it on their face too. Some women use estradiol on their face
Hmm,
actually
really?
because it's nice and firming. Yeah, yeah.
Oh, I
Yeah,
might have to try that.
especially under the eyes. Yeah, it's very firm. I mean, that's what it does vaginally for us. When we insert the estradiol vaginally,
Yeah.
it tones, it brings the pH back down. Our vagina, before we go through this transition, has these little folds, and then we go through the transition, it gets flat, so it's not holding moisture, and
Yeah.
so it helps, just helps the muscles so we don't get incontinent. It helps with that, it helps with a lot of things. But yeah, the E3 you can also use vaginally, and like I said, a lot of people use it on their face, especially
But
like
only
under the eyes.
E3.
You can use E2 on your face too, believe it or not. You can
Right.
a little tiny bit, the estradiol.
Yeah.
Yes, you can.
Wow.
Yep, yep. Yeah,
Interesting.
yeah. Skin tips. Yeah,
I didn't think about that, but hey,
yeah,
I try not for
yeah.
these lines over here. So, at what
Yeah.
stage of a woman's life would you actually recommend that they start doing hormone replacement therapy?
So I would, the typical age or average age of menopause is 52 in the US. We think perimenopause can start 10 or 15 years
Like
even
35?
prior.
Yep.
Yeah, it can. So, and perimenopause, we can draw labs, but the labs really aren't very helpful because hormones are doing a bunch of different things. We're in menopause, you're just going down. It's the zone of chaos, some people call it. Um, so, so it's really symptom based. I mean, it would want to rule out, like if somebody came to me that was in their 30s or early 40s, or really any age. I mean, we don't want to look at other things like their thyroid and whether they're anemic and some other things, if they're having symptoms. But a lot of times it's hormone changes that women are feeling, and some of the first ones are depression, anxiety, insomnia, muscle pain, lack of motivation, lack of ambition, why do I feel this way? Why can't I do, we all say that to ourselves, right? Why can't I?
Yeah.
Instead of what do I need? How nice would that, right? If we said automatically to ourselves, what do we need right now? But we typically say, what's wrong with me? And of course, if you're not feeling well, you should investigate that. But yeah, I mean, it can really start in the 30s. So it would just be, it's individualized, um, but I mean, I've started women in their 30s, I've started women in their 70s
Wow.
on hormones.
Because I
Yeah.
was under the
So
impression that it was like a 10-year window. So I don't know how true this is, that from your last period, right? Because that really does mark your menopause, like you're in menopause 12 months without a cycle. I talked about this in my prior episode that I did on the phases or stages, right?
yeah.
But after within that 10-year window is really the opportune time to go on hormone replacement therapy. Is that true?
It is true. So what we know to this point is if you start HRT within the 10-year window, you get the most benefit, but you still get benefit afterwards. We were talking before. I'm so passionate about educating women about osteoporosis. So there's two of us. One in two women will have an osteoporotic fracture, and it's devastating to their quality of life. Most women never return to their previous quality of life. I mean, it's a devastating fracture, and 35% of women don't make it past a year. 30% of women end up in a nursing home. I mean, it's a big deal. It's a big deal.
It
And
is.
so if you're outside of that 10-year window and you're symptomatic or you just want to prevent, you know, osteoporosis or you have osteopenia already, estrogen estrogen is actually FDA approved to treat osteopenia. So, even the FDA knows, is what I like to say. But yeah, if I have a risk benefit talk with people if they're outside of that 10-year window. I let them know, we think you get the most benefit in that 10 years, but there's still benefit. There's
Yeah.
definitely still benefit after that 10 years, especially, to protect your bones, to protect your heart, and to protect your brain.
Right.
Um, so yeah, yeah. And I mean, to get quality of life back in your 70s that you haven't had for 20 years.
Oh,
I mean,
it's so important.
it's big. Yeah, it's big. It keeps me doing what I do because it's a big thing for someone.
Yeah, quality of life. I mean, if you go
Yes.
through, like I went through menopause, I feel like I was early. I mean, I've been in post-menopause really for uh 7 years probably now, right? And
Mhm,
I'm
mhm.
thinking I feel young, right? People look at me, they're like, you're
Yeah,
not that old. And I'm thinking I don't feel that old. But yeah, if I have to think about the decline of osteopenia and all those other things, and I do some exercise, but I need to also do more strength training and other things. Still, I eat really well, but if I think there's 30 plus more years to go and my
yeah,
quality of life has declined, or I have a fracture, like you said, and then you end up and you've got this limp and you have other things that just make you, debilitating. It's tough.
it is. It is. And unfortunately, like mainstream medicine doesn't really, they tell you to take calcium and they tell you to do strength training, right, to protect your bones. But they really just kind of wait until you get osteopenia or osteoporosis to do something. When in the meantime, you can be preventing
Yeah.
that. And I'm not saying everybody needs estrogen to prevent it, but the vast majority of women do. I mean, we have estrogen receptors in our entire body, our brains, our breasts, our bones, our muscles. And so when we start to lose estrogen, all those receptors. There's a researcher in New York, Cynthia Mosconi, um, who just published a paper that we the common thinking was when women went through menopause, the estrogen receptors in their brain kind of downregulated, so there were less of them. She actually, in her paper, showed there's actually more. Your body, your brain is basically saying, "Give me more." Where did it go? Which makes a lot of sense for anybody who's gone through it. They know the brain fog, the lack of motivation, right? The anxiety. Yeah. I mean, there's a lot of brain symptoms, and those are some of the first symptoms that people
Yes.
have. Yeah.
Yeah.
Yeah, but I don't think most people know that. I didn't know it until I went through it and then, got more education and learned. But yeah, there's like I told you, I could talk about this forever.
It's all
Yeah.
good. It's all good
Yeah.
stuff. So you
Yeah.
mentioned
Yeah.
menopausal symptoms, right? So a lot of the common ones that we all hear about are the brain fog, the night sweats, hot flashes, those types of things, right? So I know there's also libido. Your sex drive just drops. Your energy and motivation for me was like it's hard to get out of bed, it's hard to do things. So there's a lot of various other symptoms I feel that people are not always aware of too. But how does hormone replacement therapy help with some of those symptoms?
Sure, sure. So I think of estrogen. Estrogen typically helps the most with hot flashes and night sweats. It can help some with insomnia. It can help protect our bones and our brain and our heart. So some of it, you might necessarily feel, she's kind of the introvert. I think of estrogen sometimes as the introvert. When people start estrogen, they don't necessarily always feel something unless they're having hot flashes. That it can help. Progesterone is really good for anxiety and insomnia. It there's GABA receptors in our brain that, help us stay calm. And of course, when our all of our hormones start tanking, GABA starts tanking as well. So progesterone can help with that, can help with mood in general, as can estrogen, but progesterone's claim to fame is definitely anxiety and insomnia.
And I can
And
attest
then
to that.
testosterone,
I can attest to that as well because it was, even though I was like post-menopause, you still get those symptoms, and you can get those symptoms for 10 years still, right? The same type
yeah,
symptoms, lack of sleep, low libido,
yeah,
just you name it, brain fog, but the progesterone it seemed to help a lot with some of the stress and anxiety that I was having and what was happening in my life, right? So panic attacks are also another thing that
yes,
can happen that you
yes.
don't really think of. You
Hmm.
just think, "Oh my God, I'm so stressed," but it feels very much like a massive panic attack. And I'm sure it was all hormone related
Absolutely.
because then I started on all of my hormone replacement therapy. And again, things just kind of seemed to level out, which was so wonderful.
Yeah, absolutely. It can, yeah, progesterone is usually the first one I start, not always, because once people can sleep, they can think because you can't think when you're not sleeping,
Right.
and yeah, and it usually has a pretty big bang for the buck, so to speak. Yeah, and then testosterone. Testosterone for a lot of women does help with libido. I always say to women, libido is a mood. It's biopsychosocial. So it's not just low hormones sometimes. It can be other things, that you need to address. But it does help a lot of women with libido. It's really good for anxiety, depression, and lack of motivation as well, and brain fog. Like it's really there's another researcher in the UK actually who's kind of like the godmother, really in Europe of HRT for women. Her name is Louise Newscomb, and she actually just published a paper all on testosterone and cognition and mood. And it really is good for like mental clarity and focus and energy and libido. Not always, but sometimes, it can be very helpful. and mood. So yeah, I tend to think of it as the brain, more of the brain hormone, but they all do some of the same things. It's just testosterone, is I think of it as the cherry on top. Once you get on the estrogen progesterone, yeah, I think it is like, okay, let's bring this home and start the testosterone.
Yeah.
Yeah. Yeah. I'm on all three hormones myself, so I can speak to it personally too. You know what I mean?
Yeah.
Yeah, I mean, once I started testosterone, oh my gosh, like, oh my goodness.
Yeah, it was
Yeah,
like I said, it was
I
like you're a
thought
teenager again almost, but also the clarity and the focus was there for and motivation to be able to do some things.
had forgotten that I used to feel motivated, and I
Yes.
mean, really,
You're like exercise?
yeah.
Oh, yeah.
I know. And the energy. I mean, sometimes I'll say, I get brain zoomies. I mean, really, and I don't say that like that they're unpleasant. They're not unpleasant at all. Um, so yeah, yeah, but they do all work synergistically as well. Yeah. And I also like to say too, hormones can be extremely helpful during this time of life and ongoing. But we also have to remember all of the basics like sleep and movement and nutrition because, hormones in isolation are going to help, but they're probably not going to be enough. You know, it,
Agreed.
it menopause and perimenopause is a full being transition. It is a full being, full body
It
transition.
is a transition, yes.
Um, yes, yes. And so, yeah, yeah. If those things aren't dialed in, it's a good time to get them dialed in.
Yes. And sleep is like the foundation for so many things that I feel as though um a lot of people are just overlooking that key foundation these days. And like for me, sleep is the number one thing. If I'm not sleeping, my body can literally just like shut down.
Yeah.
Besides brain fog and everything else, it becomes challenging for me to focus and get things done. So
Yeah. And we have to remember too, because we're all getting older, right? And I've worked in nursing homes. I mean, the dementia units are 90% women. And I don't say that to be scary. But like we have to take care of our brains, and sleep is when we clear
yes,
all the, dead stuff out of our brain. I
right.
mean, that is huge. It's huge. And when we're younger, we can tolerate not sleeping better. We don't think of it as
I mean,
much.
you can,
You
but
know,
still to a certain
it's
degree
not
because
good.
they like to think that you can control it or that you're young and you're going to bounce back.
Right.
But, I have teenagers and they don't bounce
Yeah.
back that quickly.
No, no. I mean, but their bodies are better at keeping themselves balanced. As we get older, it's you have to work a little bit more to stay in balance. You just do. And so those kinds of things become really crucial. Yeah,
Absolutely. Um, yeah. So the other thing I was going to ask, I know we talked a lot about, you talked about breast cancer and, heart attacks and things like that. Are there any other risks that you should, I guess, make our audience aware of in terms
sure.
of using hormone
Well,
replacement?
yeah. I mean, so what we call absolute contraindications. People that really should probably not use hormone replacement therapy. Personal history of breast cancer, not family history, personal history. And even then, some providers, depending on the situation, whether or not the breast cancer had estrogen receptors, whether or not the breast cancer had progesterone receptors, there's a lot of nuance. Some women, after they're done with treatment, do go on HRT. They do with breast cancer. But for the most part, personal history of breast cancer, personal history of ovarian cancer, a history of a blood clot that was what we call unprovoked. So it just came out of nowhere. It wasn't from an injury, wasn't from flying. So that, there might be a clotting disorder potentially. And then severe liver disease because the liver does help detoxify, the hormones. So those are the absolute contraindications,
Okay.
that people should not have it. Yeah. I mean, as far as then we could what's called relative contraindications. You know, smoking, if you were taking oral estrogen like you do in a birth control pill, not a great idea to smoke. But transdermal estrogen or the patch or the gel has not been shown to increase clot risk with estrogen. But and a lot of women take birth control pill, which is much higher dose than HRT. So
Mm.
it's just something to think about. But it again, a good prescriber, in my opinion, is going to is going to really personalize, what's going on and take someone's, personal history and day-to-day life and all of those things into consideration. But yeah, those are the big ones. If you're having unexplained postmenopausal vaginal bleeding or, something like that, that's not a good time to start on hormones. So there are a few things like that, but for the vast majority of women, it's very safe. There was a study in 2002 called the Women's Health Initiative. Big study. It's what scared the bejesus out of everyone. Women got ripped off their hormones because the study was said that it, hormones increase the risk of breast cancer.
Mhm.
But, the study has been looked at and looked at and re-looked at, and it was poorly designed and it was poorly interpreted. They were synthetic hormones. So, horse urine estrogen and synthetic progesterone, which is called a progestin. So, and even in that study, the synthetic estrogen alone showed a decreased risk of breast cancer. So you have to kind of look back on it. There's a really good book called Estrogen Matters that walks through a lot of that. And it's written by an oncologist, lots of references in it. There's a lot of good books out there, but that's one of the better ones, I think. Because I know that that's a lingering thing in a lot of people's minds that it's going to cause breast cancer. And all of our latest evidence says absolutely not. It actually shows it's preventative for some cancers, including colon cancer.
Wow.
So yeah, yeah. So yeah, it just hasn't all caught up, unless you're seeking this information out. A lot of medical providers don't know this. They still tell women that it's going to give them breast cancer. So yeah, it has to be a prescriber or a provider that's, really done extra education and knows the latest evidence and is continuing to educate themselves, because it's changing constantly, like everything.
Absolutely. I
Yeah,
mean, in
yeah.
going to your regular gynecologist, you would think that you would get information like this. And I have to say, when I was going through some issues, right? And with libido and other stuff, I'd go into the OBGYN and have that discussion like, yeah, you're like, I'm in menopause. And they're like, oh, well, okay. I said, I'm having all these symptoms. And they said, well, I said, what can you do for that? And they said, nothing really. We can give you some estradiol and that's about it. And I was like, well, wait a second. That's it? I mean, and what is that going to do for
Yeah,
me? Not too much, really. It'll
yeah.
help a little bit with your, the dryness that you're having, which was really bad, but
Mhm.
I'm like, there has to be more to the issue than this, right? It has to be a better solution.
Yeah, yeah. Most OBGYNs get like a couple hours of menopause care is what I've learned. They don't
Yeah.
get a lot. Their main focus like is delivering babe, right? Yeah, they don't get a lot of menopause care. And they're busy, right? And they don't have the bandwidth or the time or whatever to learn. So I unfortunately shut a lot of women down. I just had someone tell me yesterday that Planned Parenthood told her there's no way she's in perimenopause. She's 47, she's having all these crazy symptoms, and they're like, nope, no, you're not in perimenopause. Yeah, can you imagine? I yeah. No, you don't know what you feel in your body. You
Right. I mean,
couldn't possibly know what you feel in your body.
yeah, we know our
How could
bodies
you
better than
know? Yeah,
if anyone, we
yeah,
should
I
know our
know.
bodies. Yeah,
Absolutely, absolutely. And when you said earlier about I think you said something about me being the expert or something, I always say to women, like you're living in your body. I know things, yes, and I have some experience, but you're living in your body. Tell me, I mean, this is how I want to be treated when I go see someone. So, it's important, like I think shared decision making, like we're taught shared decision making, but almost nobody practices it. That's what it needs to be. It needs to be a shared decision, you know?
agreed. It
Yeah.
needs to be a team
Yeah.
effort with you and any practitioner that you're working with, right? They need to know not just what your symptoms are, but they also need to sometimes know all the other things that are happening in your life that are causing stress. Are you exposed to toxins? Are you exercising? It's not just your physical body or even some of the mental issues that you can bring in as complaints or symptoms. It's the whole package that seems to not really be investigated, and which is why I love naturopathic medicine because, it's the root cause, it's looking at it in its entirety, everything that you're exposed to.
Yeah. And it's a holistic view.
Yeah,
You're not looking just at, one part. Like you have to step back and really look at the whole person. And I know, there's a lot of lip service given to this, but it actually has to be like played out, yeah. And yeah, I think we don't deserve anything less than that. Really. We don't. It's just it can be very difficult as to find the person and to be heard. And yeah, there's just so many things. And I don't think I said this, but I mean, I'm doing this because I went through menopause and nobody would help me.
uh,
You know, I got the
yes,
same thing. And
that's
and
why I got
the
educated.
way, yeah, it's how I ended up doing this and where I am because I just became so passionate about it. And I have a daughter as well. So, I keep right. I don't want her to suffer like I suffered and not sleep for 3 years and all of those things when you don't have to. You don't have to. And some women, they don't take hormones and they feel fine. I would still argue for them the prevention potentially, because I do worry. I really worry for women's bones, especially. But you know, at least you should be given the information and the option of HRT, if it's right for you.
I agree. Another question for you is urogenital health post-menopause and nutritional needs.
So urogenital health post-menopause. Number one would be vaginal estradiol or, a combo estradiol, estriol. You can use that as well. Because as I said before, when we go through menopause, our vaginas are typically very acidic. So we lose that acidity, which predisposes us to urinary tract infections, which can be really, they can be like people can get septic and, end up in the ICU from a urinary tract infection. Um, and we lose those folds, like I said, like things flatten out. We're not making as much moisture. We lose our muscle tone. So the vaginal estradiol or, some form of vaginal estrogen will help with all of that. It helps keep the muscles tone. It helps replenish the pH. It helps keep it more acidic. It gives us moisture. Women can use coconut oil. It can help keep things moist too, but it's usually not enough. I mean, maybe in the beginning, but ongoing. And then, there can be painful sex when, things don't, when you're dry and, and again, you don't have the folds, everything's flat. So, again, the cream, the coconut oil, the vaginal estradiol, sometimes you can use DHEA, which is a precursor to testosterone. There's a commercial product called Intra Rosa, which is really pricey. But there are like little ovals of DHEA that you can use to also help there. Sometimes we use vaginal testosterone too. Sometimes just a little bit on the clitoris because some women say like they lose sensation, or they're not able to orgasm as well. So sometimes that can help. But yeah, it really comes down to losing the hormone. That's really going to give you the most support for your genitourinary system, after menopause, definitely.
Yeah,
And
I
cotton
agree.
underwear, all of the basic stuff too. Yeah, yeah, for sure. Yeah, no douching. That is usually very drying. Yeah, yeah. And then I don't know, I know you have a nutrition background. I'm not sure. I
Yeah,
mean,
so on the nutrition side, a Mediterranean diet is usually good. Not to like throw out any specific diet, but it's really more just eating a lot of vegetables so that you can get all the nutrients that you need and the phytochemicals and all of that. And having some good lean proteins because the lean proteins are going to help to retain some of that muscle mass, right? To be able to not get osteoporosis. Hopefully, obviously, you have to exercise too, but eating cruciferous vegetables like broccolis, cauliflowers, Brussels sprouts, kale on a regular basis. Also, taking some fiber, like ground up flaxseed. I take ground is the way to go, not like the whole seed because that actually can help as well with balancing some of the hormones. So, like in a
mhm,
smoothie on your yogurt with some fruits, lots of colorful fruits and vegetables too. Just having that and having lean proteins like fishes, wild caught salmon, anything that's organic for your chicken and grass fed beef, things like that, just kind of helps to maintain again some of the muscle mass, but gets in some of that fat. Avocados are great for the fat content that you're going to get there and not to worry about gaining midsection fat, right? Because we actually need some fat because that will
yes,
adjust
we
too,
do.
right? Most women usually see that that is where the first spot that we realize we're actually kind of perimenopause, I think, because you get that midsection or mid waistline growing. Um, so yeah,
Yeah,
just
and
some
that's
general health general good practice with eating a Mediterranean-ish diet with some good fish and proteins and drinking a lot of water, but not yet too much water. And I can attest to kind of going back to your statement about that stage where urinary tract infections and that kind of not really incontinence, but like that burning feeling because it gets dry,
mm,
right? So
yeah,
having those hormones really made such a difference. And I also take now because I had gone to that's the reason why I went to the OBGYN was because I was feeling like I had a urinary tract infection. And they're like, nope, you don't. And I'm like, well, it feels like that. Well, no, it could be prolapse. It could be something else, but no, we're not seeing that that's what it is. And I said, okay. And then I just started taking some cranberry juice and coconut water and it
yeah.
flushed itself out. And then I now
Yeah, I was
just
going to mention cranberry. Yes. Yeah. Yeah, no, I'm glad you did. Yeah. Yeah, because we can feel it even before it shows up in a urine. Yeah, again, listening to the person that's living in the body.
Yeah, and I think we all need to start just listening to our bodies and not listening necessarily to the symptom, but how are you feeling in relation to what's going on in your entire body? And the doctors don't know everything. And that's why I do a lot of things now with just female practitioners because one, as you said, not a lot of them are getting the education on menopause and or any other women's specific things. Like our heart attacks are completely different symptoms than men's, right? But a lot of the doctors that are men are taught that in that I feel male's perspective of, you're going to get chest pains when you have a heart attack. Well, women don't really get that, right? It's a little different for us. We get very tired. It's just very lethargic, and you don't really get that heart wrenching chest pains that guys do. Some may, but so I feel like going to a woman that actually can empathize one and kind of understands what you're going through is just a huge benefit.
Yeah, it can be helpful for sure. Yes, yes. When
Absolutely.
you're talking to somebody who, even if they haven't gone through it, they they're gonna listen to you. It's not rocket science.
It's not wrong.
It's not. I know, because yeah, I mean, who doesn't want to be heard? Of course we want to be heard, especially when we don't feel good. we want somebody to listen and help us feel better. So yeah, yeah,
Absolutely.
definitely.
And one other question on like physical and cognitive declines using hormone replacement therapy, which we kind of touched on a little bit before, but I didn't know if there was anything else you wanted to add specifically to that.
Yeah, I mean, hormone replacement therapy is for sure going to be a big piece of aging powerfully. Like, you know, I mean, we're living longer. We have access to so many more things than we ever did, right? We can really age powerfully and, and keep our minds and our bodies healthy. Of course, there's going to be things, right? Because, yeah, we're But yes, hormone HRT is a big part of that. I mean, it helps you keep your muscle, it helps you keep your bone. You have to do other things like we talked about. It definitely helps with cognition. I mean, you can do crossword puzzles and you can read, and those things are all great. But we have so many hormone receptors in our brains, and when we're not getting the hormones, they're not going to do as well. And I know some people, they'll say to me, because I work in a naturopathic office, right? They'll say, but hormones aren't really natural. And I just say, well, I mean, we replace insulin if you need insulin. We replace thyroid hormone if you replace thyroid, and we're using um, biosimilar or molecularly the same, substance as what your body makes. And, like glasses aren't natural either, but they help me see better. you know yeah, so yeah, I know some people do ask that question because I think probably a lot of people that are on here with us are more naturally focused, and I get that. I am as well. um but I do think they're a big piece of that puzzle for aging, with our mm, aging and enjoying our lives,
Yeah, it goes
living
back to
vibrantly.
quality of life.
Yeah, absolutely, absolutely.
Well, this has been fantastic, Natalie. I really appreciate you providing so much beneficial information to all of us on hormone replacement therapy, the pros and cons, and kind of digging in deep into some somewhat personal things. But it was great information, I feel like, to share. And I know that you mentioned that you're with a naturopathic company. So do you want to share a little bit about New London Natural Health Center?
Sure, sure. So yeah, so it's New London Natural Health Center. We're in New London, Connecticut. We have three naturopathic doctors and two nurse practitioners, myself and Natasha, which people get us confused sometimes. You can understand why, Natasha and Natalie. Um, yeah, and one of our naturopathic doctors is also an integrative cardiologist, Dr. Nikolai. And yeah, we, the clinic isn't what drives us isn't numbers and productivity. Like that's not like someone's not looking every day and saying, "Oh, you only saw three people today. You were supposed to see 12." So it's really community focused and whole person focused. When you go onto our website, it says we treat people, not diseases, but really that's our philosophy. And we each have our strengths. Like I said, Dr. Nikolai is integrative cardiologist. Dr. Serum works with adults, but also works with children. So yeah, we have, and we even have a primary care component. Natasha, the other nurse practitioner, does some prescribing for high blood pressure and hypothyroidism, but the doctors in the clinic are primary care providers. Yeah, so yeah, it's I they're almost 3 years now, and I love it. I mean, it's really is my passion. It was what been meant to do, all this time. I've been doing this a while, but this is it. Yeah, everything else I did led me to this.
That's awesome. I appreciate them sponsoring today's episode and allowing you to come on and talk with us about all of this most important information on hormone replacement therapy. So I did post in the chat for anybody that wants to grab the links to to our sponsors. So you can go out and check them out for the New London Natural Health Center. And you can also look up Natalie on there if you ever wanted to contact her about hormone replacement therapy. I'll also put out there the links to the Limitless Ladies Network. If you haven't been out there, I encourage you to sign up to our email list. You can get an access to this recording afterwards, and you can also forward it to anybody else that wasn't able to join. And also follow us on Facebook, YouTube. We have our YouTube channel where this will be posted as well. And we also have a podcast. So if you can't watch it, you can always listen to it. So we hope to see you on another episode. Thank you.
Thanks for having me.
Thank you.